Thank you so much. My background is in stigma research. I'm a researcher, and Rob has asked me to kind of lay the foundation for tonight by talking about what stigma is and what it isn't. And so I thought that I would just give us a little bit of a background on how I understand stigma, which is not necessarily the way everybody does, but maybe that will be enough to get us all on the same page for tonight at least. So if anybody can't hear me, just start waving and shaking and I'll try to speak up a little bit, but I think we're good. So when it comes to stigma definitions in the scientific literature, at least, they've changed over time. So what we used to think about stigma in the old days, in the 1950s and 60s and 70s, is not how researchers are talking about it today. And I think that much of the crosstalk that we have in the community is because we're using different terms and meaning different things by them. And so hopefully I can bring you up to speed on how we're thinking about it as scientists. And I like the way we're thinking about it recently because we're very much thinking about a social justice and a human rights perspective. And I think that's the way to go here because I think stigmatization of mental illnesses is a human rights issue. And I think we have to be very clear about that we need to be fighting for people's human rights. In the old days, we used to think that stigma was a mark of shame that a person bore because they had a mental illness. And that put all of the emphasis on the person, as if it was somehow their fault. They had the mental illness, they bore the stain, they bore the mark, they were somehow tainted. And that was probably about 1950 that we saw that definition coming up. And then later on in the 70s, we heard about psychology researchers talking about the way in which we stereotype people, the kinds of thoughts we have about people with mental illnesses. And they came up with things like people can control their mental illness. People in the public think that those with a mental illness can control what they're doing. They could snap out of it if they wanted to. They're violent, they're dangerous, they're unpredictable, they're disabled too disabled to work. All of these stereotypes started to float, things that we think, but they were focusing on the stereotypes. Again, with a lot of emphasis on the person who has a mental illness, and not so much blaming the social group. And lately, we've been thinking that it really is the fault of the social group. So think about people in wheelchairs. They can be totally included in society if we have ramps, if we have access points in buildings so that people in wheelchairs can get into buildings, if we eliminate staircases. We're talking about universal design where ramps go into all the buildings. So people in wheelchairs are able these days, in most cases, to be socially included. And that's because our social group, our society, made a decision to do this. And so when it comes to people with mental illnesses, we've not made that decision as a social group. We exclude people because we can. And so we're thinking about this now as a form of social oppression. People are stigmatized in a way that the society oppresses them. And one of the key ingredients in social oppression is power. So you cannot be stigmatized if you have social power. It's only the disempowered, the disenfranchised people that can become stigmatized. So we've gone from a position where we equate stigma with an attitude. We talk about stigma and discrimination, thinking about the attitude versus the behavior, to a point where we're thinking about a very complex social process, the stigmatization of people with mental illnesses that is very much based in a power differential, is a violation of human rights, and it's a problem of social justice. And you'll be happy to hear that the United Nations Convention on the Rights of People with Disabilities is very much positioning stigma in that context. and is putting a duty on countries to actively reduce social, structural, personal barriers to stigma. And Canada is a signatory to the United Nations Convention. So we have now an international responsibility to think about ways in which we can reduce stigmatization and make sure that people with any disability, including a mental health related disability, can become, in their words, full and effective members of society. It puts an onus on our federal government to think about how they can do this. It puts an onus on our provincial governments to think about how they can do this. It puts an onus on municipal governments. Now, unfortunately, they haven't really caught up to this thinking yet. But if we could do one thing tonight, it would be my wish that we would start thinking about stigmatization. Stop talking about stigma and talk about stigmatization as this broad social process that denies the rights of people who have disabilities, whether that's a mental or a learning disability or a physical disability. When we think about stigma, how it transforms itself into society and how it affects people, we really think about 3 different levels of activity. And if you think about society as existing before you, you're born into a social group. Your social group, through your family, through educational systems, through the media, which I'm sure Rob will touch on, they teach you how to think about things, not just mental illness, but all things. Religion, families, whatever. You learn from your social group. So you learn about mental illnesses as well. And so from a very early age, you're already starting to develop stereotypes and biases and prejudices about people who have a mental illness. And you do it because you watch TV, because you listen to your parents, because you hear things from your friends, you hear snide comments from whoever. So by the time you're 12 or 13 or 14, you know exactly how you should think about somebody who has a mental illness. Think of the Looney Tunes cartoons. Remember those? Does anybody who ever watch those anymore? But I mean, they really set things up. The Disney animated cartoons, about 80% of them show characters who are disorganized, and they portray them in a sort of a mentally disorganized way. So we're teaching our kids how to think about mental illness. And what ends up happening is you and I and everybody in this room has learned all of these things, and they become ingrained and kind of hardwired into our brains. And if one of us were to become mentally ill, we know exactly how other people are going to think about us because we've grown up in the same culture. And we have internalized some of those beliefs. We tend to think that we're not trying hard enough to get better. I've heard people tell me that. If I only tried hard enough. They're afraid to come forward for help because they don't want to be stigmatized. They know how their friends and their family and everybody is going to treat them. So there's this element of this structural level of stigma, the institutions, the media, the schools, the families, how they teach us to think about mental illnesses. And that becomes internalized, and we call that self-stigma. And we start to believe the PR. We start to apply all of those things to ourselves. And so self-stigma is a very difficult thing for people with mental illnesses to address and overcome. And we're actually having some very good luck in Kingston, talking with people who have mental illnesses and helping them understand that many of the barriers that they face are because of self-stigma. They're putting them up themselves. So there's this whole other area of public stigma that we need to talk about, which is how the general public thinks about those with a mental illness. And what we do know, there's not a lot of research in this area, but we do know that it depends on the diagnosis. So people are more apt to believe that somebody with a substance use disorder is going to be dangerous. than any other diagnostic group. This is American data. I don't know if this would hold true in Canada because Americans have this weird thing about substances. So they have this war on drugs. We don't have it here to the same extent. But so schizophrenia comes next. I think about, if I can remember the numbers, about 60% of the sample thought that those with a diagnosis of schizophrenia would eventually be dangerous. And so if you think someone's going to be dangerous, you're going to try to keep your distance from them. You're going to shun them. You're not going to want them in your family. You're not going to want to have them as friends. So a lot of the work that we do is based on these measures of social distance that try to get at how comfortable people are in interacting with someone who has a mental illness. So substance abuse was the worst, then schizophrenia, then depression. Even about 30% of the public thought that those with depression would be ultimately dangerous to others, which is incredible to think about. They're more likely to be dangerous to themselves. And not only that, but people with any mental illness are more likely to be victimized than they are to commit an act of violence. And then the last category was they were defined as being troubled, just troubled. So they have an emotional trouble. And the general public thought, I think it was about 15 or 20% of those would be considered to be dangerous to others. So this is the nature of this hardwired stereotype that we have. So the general public projects these images, they socially distance themselves. Then you get to the media component, and that just kind of incites the whole thing. So generally we have three levels. Then we have the social structural level, which has to do with our institutions, our policies, acts of commission where we deliberately reject people, acts of omission where we don't give people what they need. We have the public level, public stigma, which is how people think about each other, and then we have self-stigma. And unfortunately, these things work like cogs in a wheel, a big machine. So if you try to deal with one, the other wheels just keep grinding along. And the challenge for the anti-stigma researchers, those of us who are trying to implement programs, is how do we implement these multi-level programs that will attack not only the self-stigma and the public stigma, but the structural stigma as well. And for my money, I would aim my guns at the structural stigma, because that's what's teaching our babies and our children how to think about mental illness. And I think I'll stop there.
Thank you very much.